Welcome to Teaching Service Hospital Rounds. Today we are covering Crohn disease. If ulcerative colitis was carried by three words, mucosal, contiguous, and rectum, then Crohn disease is carried by one, transmural. Inflammation that goes through the full thickness of the bowel wall. Hold on to that single word, because almost every complication we discuss today falls out of it. Crohn disease can appear anywhere from mouth to anus. It skips, and it tunnels. We will follow one young man from his first clinic visit, through his workup and his plan. Let us begin. Crohn disease and ulcerative colitis are the two inflammatory bowel diseases, and separating them correctly changes management at every step. Here is our patient. A 23-year-old man comes to clinic with 6 months of symptoms. He has crampy right lower quadrant pain, and it is reliably worse after he eats. He is having 4 to 6 loose stools a day. There is mucus in them, but he has not seen blood, and he has lost 8 kilograms without trying. 6 months. Weight loss, postprandial pain. Notice already how different this sounds from the young woman with ulcerative colitis. She led with blood, he leads with pain. He is otherwise healthy, and takes no regular medications, and he has never been hospitalized. Here is what to take away. First, define Crohn disease and separate it cleanly from ulcerative colitis, and explain exactly what transmural inflammation causes. Second, recognize the clinical presentation. Name the disease distribution patterns, and use the 2 activity scores. Third, diagnose it with ileocolonoscopy plus small bowel imaging. Recognize the endoscopic and histologic findings, and apply the Montreal classification. And fourth, manage the 4 structural complications, perianal disease, stricture, fistula, and abscess, and predict the malabsorption that follows ileal disease. Drug selection by severity belongs to its own video. So today we stay on the disease. Let us take the history properly. 6 months of crampy right lower quadrant pain, and here is the detail that matters. The pain reliably comes on about 30 minutes after meals. He has 4 to 6 loose stools daily with mucus in them. He has not seen gross blood, though he admits he has not looked closely, and he has fatigue, malaise, and 8 kilograms of unintentional weight loss. Now reason about that. Postprandial pain plus weight loss points you at the small bowel, not at the colon. Food is meeting resistance somewhere upstream. He also describes his stools as loose rather than watery, which fits an inflammatory rather than a secretory process. Now the rest of the history. He is 23, right inside the first incidence peak. He smokes half a pack a day and has for 5 years. Hold on to that. A year ago, he had what he was told was a hemorrhoid drained. He has no known family history of inflammatory bowel disease, and he gets recurrent painful mouth ulcers. He was previously told he had irritable bowel syndrome. Now go back to that drained hemorrhoid. In a young man with chronic diarrhea and weight loss, that was almost certainly a perianal abscess. And note he has no family history. Most patients with Crohn disease do not, so its absence never reassures you. On examination, he is thin. His temperature is 37.6 degrees. There is fullness and tenderness in the right lower quadrant, which is the terminal ileum. There is no rebound and no peritoneal sign, so no free perforation today. Look in his mouth, and you find 2 aphthous ulcers on the buccal mucosa. And now the examination residents skip the perineum. He has perianal skin tags and a healed fistula opening. In this patient, the perianal exam is effectively the diagnosis. 2 minutes of exam, and the whole case changes. His abdomen is not distended and bowel sounds are normal, so he is not obstructed today. His laboratory studies. Hemoglobin is 10.8 with a low mean corpuscular volume. Albumin is 2.9, low, and C-reactive protein is 68, markedly raised. His vitamin B12 is low, and his vitamin D is low. His fecal occult blood test is positive, even though he told us there was no blood. And his stool infectious studies are all negative. Now read that panel as a whole. A low B12 together with a low albumin is telling you the terminal ileum is involved. That is where B12 is absorbed and nowhere else. A C-reactive protein of 68, in a young man with 6 months of symptoms, is not irritable bowel syndrome. Let us get the definitions exactly right. Crohn disease is transmural inflammation. It involves the full thickness of the bowel wall. It can occur anywhere from the mouth to the anus, and it produces skip lesions, patches of disease with genuinely normal bowel in between. Ulcerative colitis is inflammation of the colonic mucosa only, contiguous, always beginning at the rectum, and confined to the colon. Same 2 words separate them, depth and continuity. And essentially everything distinctive about Crohn disease follows from that one word, transmural. Write both definitions out from memory, until they are automatic. Look at the two panels again. On the left, ulcerative colitis. Only the mucosa is inflamed. The inflammation stays superficial and cannot leave the bowel. On the right, Crohn disease. All four layers are lit up: mucosa, submucosa, muscularis propria, and serosa. Now think about what a full-thickness inflammatory process can physically do. It can tunnel out of the bowel and reach another organ. That is a fistula. It can scar all the way around and narrow the lumen. That is a stricture. And it can seed infection outside the wall. That is an abscess. Ulcerative colitis, staying in the mucosa, does none of those three things. The epidemiology is essentially the same as ulcerative colitis, because these two diseases share a family. The first and largest peak of onset is between 15 and 30 years, which is where our patient sits. There is a second smaller peak between 50 and 70. The male-to-female ratio is 1 in North America, and prevalence is higher in Caucasian and Jewish populations. Note what this means practically. Age and demographics will not tell you which of the two diseases you are looking at. Only the pattern of disease will. What does differ is behavior, and behavior is what the rest of this video is about. Follow the chain across the screen. It starts with genetic predisposition. Then an environmental factor is added, a defective mucosal barrier, and importantly, smoking. Together those produce T-cell dysregulation. The immune system loses tolerance to the ordinary bacteria in the lumen. And that drives chronic inflammation. But in Crohn disease, the inflammation goes all the way through the wall. That last box is the whole difference: transmural inflammation. And out of it come the fistulas, the strictures, and the abscesses we will spend the rest of this video on. Notice that the first three boxes are shared with ulcerative colitis, only the last one differs. Smoking deserves its own slide because it is the one environmental factor you can actually change. Smoking increases the risk of developing Crohn disease. Note the asymmetry here. It does not do the same thing in ulcerative colitis. This is genuinely a Crohn-specific risk factor. And beyond simply causing the disease, smoking is associated with more aggressive behavior and with more surgery. So cessation counseling is not a generic health message tacked on at the end of the visit. In Crohn disease, it is a disease-modifying intervention. Put it in the plan every time. And it is the one question in the history that most changes what you tell the patient to do. Now the clinical picture. Abdominal pain is the dominant symptom, and that alone separates it from ulcerative colitis, where bleeding leads. Patients have loose, frequent stools. The diarrhea is mucus-containing and often non-bloody. And there is malaise and weight loss, which reflect both inflammation and malabsorption. Hold the contrast in your head. In ulcerative colitis, the patient describes blood. In Crohn disease, the patient describes pain and weight loss. When a young adult has had months of both, stop calling it irritable bowel syndrome. The pain reflects a thickened, inflamed bowel wall trying to move contents through. But do not conclude that Crohn disease never bleeds. Up to 50% of patients have a positive fecal occult blood test. So blood is common. It simply is not usually visible. The bleeding is slower and higher in the gastrointestinal tract, so it is mixed and degraded by the time it arrives. Here is the practical consequence. A patient who tells you he has never seen blood has told you almost nothing. Our own patient denied blood, and his test came back positive. So test rather than ask. A negative history is not a negative test. Check iron studies too. Chronic occult loss is the usual reason these patients are anemic. Now recognize obstruction developing. Watch for nausea and vomiting, bloating and distension, and obstipation, meaning no stool and no flatus at all. And listen for a change in the character of the pain. It becomes colicky and wave-like rather than constant. Here is the rule. A young patient with known Crohn disease and obstructive symptoms has a stricture until proven otherwise. That is transmural scarring, narrowing the lumen. It is not simply a bad flare, and treating it as one with more steroids will not open the bowel. Get cross-sectional imaging rather than simply increasing the steroid dose. The extraintestinal manifestations are the same list as in ulcerative colitis, so we can move quickly. In the skin, erythema nodosum, pyoderma gangrenosum, and aphthous ulcers. In the eye, uveitis, which threatens vision and needs urgent ophthalmology, and episcleritis, which is milder. In the joints, seronegative arthritis, which is the most common extraintestinal manifestation of all. And in the blood, thromboembolic events, highest during an active flare. And look back at our patient. He already has the aphthous ulcers. Ask about them directly at every visit. Patients rarely connect a rash or a sore eye to their bowel. Two scores are used to measure disease activity. The Crohn Disease Activity Index, the CDAI, is the trial standard. It combines symptoms, Physical findings, hematocrit, and weight into a single number. It is thorough but cumbersome at the bedside. The Harvey-Bradshaw Index is the simplified version. It uses general well-being, abdominal pain, stool count, the presence of an abdominal mass, and any complications, and you can compute it in the room. Pick one and use it consistently. The value lies in tracking the same score over time, not in which one you chose. Both scores are also how you will read the inclusion criteria of any trial you encounter. How do we make the diagnosis? Ileocolonoscopy with biopsy, along with a small bowel assessment. Read that carefully. Colonoscopy alone is not sufficient in Crohn disease, because a quarter of patients have disease confined to the small bowel where a colonoscope cannot reach. So you need cross-sectional small bowel imaging as well, and magnetic resonance enterography is the usual study. And there is one step that must never be skipped: intubating the terminal ileum. If the endoscopist did not enter the ileum, the most commonly involved segment was never examined. Capsule endoscopy is an alternative for the small bowel, but avoid it if a stricture is suspected. Now where the disease actually lives. Small bowel disease alone, ileitis, accounts for about 25% of patients. Ileocolonic disease, involving both the terminal ileum and the colon, is the largest group at about 50%. And colonic disease alone is about 25%. Isolated upper gastrointestinal tract disease is rare. Now notice the practical point. Half of all patients have ileocolonic disease, which is exactly the pattern that requires both a colonoscopy and small bowel imaging to see completely. One test alone would miss part of it. So always ask which segments were actually examined before accepting a negative workup. What does the endoscopist see? First, the mucosa is non-friable, and that is a real distinction. In ulcerative colitis, the mucosa bleeds when the scope touches it. Here it does not. Second, cobblestoning, produced by linear and transverse ulcers crossing each other with swollen mucosa in between. Third, aphthous ulcers, which are the earliest visible lesion. Fourth, deep and long fissures. And fifth, skip areas, segments of entirely normal mucosa sitting between diseased ones. Non-friable mucosa with skip areas is the endoscopic signature. Take biopsies from diseased and normal-appearing segments alike. The contrast is diagnostic. Now the histology. The pathologist reports transmural inflammation with a mononuclear cell infiltrate. That word transmural on a report is diagnostic weight. You may see non-caseating granulomas, along with fibrosis, ulcers, fissures, and skip areas confirmed across segmental biopsies. Now here is the most important caveat in this whole video. Granulomas are seen in fewer than 25% of mucosal biopsies. So more than 3/4 of Crohn patients have no granuloma on their biopsy. Their absence never excludes the diagnosis. Do not let a report talk you out of it. Report the absence of granulomas as a finding, never as an exclusion. The Montreal classification is how Crohn disease gets described in referrals. It has 3 axes. A is age at diagnosis, and younger onset tends to run a more aggressive course. L is location, ileal, colonic, ileocolonic, or isolated upper tract, with a modifier if the upper gastrointestinal tract is involved. And B is behavior, stricturing versus non-stricturing, penetrating versus non-penetrating, with a modifier for perianal disease. Behavior is the axis that changes over time. Patients migrate from purely inflammatory disease into stricturing or penetrating disease as years pass. Recording it properly at diagnosis lets the next clinician see how the disease has moved. Perianal disease occurs in 24% of patients, and here's the part that catches people out. Perianal disease may precede intestinal symptoms entirely. It includes fissures, fistulas, skin tags, and perirectal abscesses. So a young adult presenting with a recurrent perianal abscess deserves a workup for inflammatory bowel disease, not just another incision and drainage. And that is exactly what happened to our patient a year ago. He had an abscess drained. It was called a hemorrhoid, and nobody asked why a 22-year-old was getting one. Examine the perineum at every visit in a patient with Crohn disease, not just the first one. Stricture is the next complication. It occurs typically in the small bowel, and the classic symptom is postprandial abdominal pain, which is precisely what our patient described. Think about the mechanics. A meal arrives. The bowel tries to push it through a segment that transmural scarring has narrowed, and that produces pain about half an hour after eating. Left alone, a stricture can progress to complete small bowel obstruction. And because it is fibrotic rather than inflammatory, it often requires surgery. Immunosuppression does not reverse established scar tissue. Distinguishing inflammatory narrowing from fibrotic scar is what the imaging is for. Fistulas are transmural inflammation, finding its way out of the bowel. They are named for where they tunnel to. Perianal, the most common. Enteroenteric, bowel to bowel. Rectovaginal, which is devastating for quality of life and often underreported unless you ask directly. Enterovesicular, bowel to bladder. And enterocutaneous, bowel to skin. Here is a clinical pearl. Recurrent urinary tract infections in a patient with Crohn disease, particularly with air or debris in the urine, is an enterovesicular fistula until disproven. Ask about air or stool passed per vagina or per urethra. Patients almost never volunteer it. Abscess is the complication that is most often missed. It presents with fever, a tender abdominal mass, and a rising white cell count. That sounds easy to spot. And here is why it is not. Steroids mask the signs. A patient on steroids may have a blunted fever, much less tenderness than the pathology warrants, and a white count that has been artificially suppressed. So the examination can look deceptively benign over a real collection. What you need is a high index of suspicion and cross-sectional imaging, not a reassuring abdomen. A patient not improving on adequate therapy is an imaging decision, not a dosing decision. Let us stay with that for one more slide because it is where patients get hurt. Steroids blunt fever, blunt tenderness, and blunt the white count. So the patient looks better than they are. Their ongoing symptoms then get attributed to the flare itself, which seems reasonable. So the team escalates immunosuppression, and that makes an undrained abscess considerably worse. Here is the rule to take away. In a Crohn patient who is not improving on treatment, image before you escalate immunosuppression. Ask what you might be missing rather than assuming you need more drug. Computed tomography or magnetic resonance imaging of the abdomen and pelvis is the study. Follow this chain. It is worth memorizing whole. It begins with ileal disease, or with surgical resection of the ileum, because the terminal ileum is where several specific things are absorbed and nowhere else. Lose bile acid absorption and the patient forms gallstones. Lose fatty acid absorption and unabsorbed fat binds calcium in the gut, which frees oxalate to be absorbed and deposited as calcium oxalate kidney stones. And lose fat-soluble vitamin absorption and you get vitamin D deficiency, which leads to osteopenia. One anatomic site, 3 separate downstream complications. Notice the kidney stone step. Unabsorbed fat binds calcium, which frees oxalate for absorption. Let us put those in order explicitly. Reduced bile acid absorption leads to gallstones. Reduced fatty acid absorption leads to calcium oxalate kidney stones. Reduced fat-soluble vitamin absorption leads to vitamin D deficiency, and from there to osteopenia. And add vitamin B12, which is absorbed in the terminal ileum and nowhere else in the gastrointestinal tract. So ileal disease or resection produces B12 deficiency directly. Practical instruction. In anyone with ileal disease or an ileal resection, check vitamin B12, check vitamin D, and get a bone density scan. Repeat those studies periodically. Deficiency develops slowly and silently over years. Now prognosis at 1 year. About 50% of patients are in remission. About 20% are in a flare at any given point. About 20% have low disease activity, and about 10% have chronic active disease that never settles. Read that as a whole. Half of patients are well at any given moment, which is genuinely reassuring for a young person hearing this diagnosis. But the other half are not. And the disease rarely simply disappears. Set that expectation at the first visit, rather than at the first relapse. Those numbers also mean roughly 1 patient in 10 never achieves a durable remission. And prognosis at 20 years. The majority of patients will have required some surgery. And here is a critical distinction from ulcerative colitis. Surgery is not curative in Crohn disease. In ulcerative colitis, removing the colon removes the disease. In Crohn disease, the disease characteristically recurs at the anastomosis, because the process is not confined to one organ. Overall life expectancy is slightly reduced. A real but modest reduction. Unlike ulcerative colitis where life expectancy is unchanged. Say both of those plainly. The honest number builds more trust than the reassuring one. Post-operative prophylaxis is used precisely because recurrence at the anastomosis is expected. This table is the one to memorize. Depth, transmural versus mucosa only. Distribution, skip lesions versus contiguous from the rectum. Location, mouth to anus versus colon only. Diarrhea, often non-bloody and mucus-containing versus grossly bloody. Mucosa at endoscopy, non-friable, and cobblestoned versus friable with lost vascularity. Granulomas, non-caseating in under a quarter versus absent. Perianal disease, 24%, and it may come first, versus absent. Smoking, increases risk versus not a risk factor. And surgery, not curative versus colectomy, cures the colitis. Around 10% of colitis cases remain unclassified at diagnosis, and that is an honest answer. The pitfalls that cost patients. First, calling 6 months of pain and weight loss in a young adult irritable bowel syndrome, which is exactly what happened to our patient. Second, never examining the perineum. Third, excluding Crohn disease because the biopsy showed no granuloma. Remember, over 75% of biopsies have none. Fourth, escalating steroids in a patient who is not improving without first imaging for an abscess. And fifth, forgetting vitamin B12, vitamin D and bone density after ileal disease or resection. Those deficiencies are silent until they are not. And sixth, attributing obstructive symptoms to a flare when a fibrotic stricture is the cause. Back to our patient. He had an ileocolonoscopy with biopsies plus magnetic resonance enterography. The terminal ileum was ulcerated and cobblestoned. There was patchy right colon disease, and the rectum was entirely spared. Biopsies showed transmural inflammation, and no granulomas were seen, which, as we said, changes nothing. The enterography showed a 12-centimeter diseased ileal segment with no abscess and no fistula. Now put it together. Rectal sparing, skip lesions, and normal mucosa in between. This is Crohn disease. The terminal ileum was successfully intubated, which is the step that made this diagnosis possible. So the assessment and plan. Ileocolonic Crohn disease, moderately active. In Montreal terms, that ISA2, adult onset, L3, ileocolonic, and B1 with a P modifier, inflammatory behavior with perianal disease. Where place his vitamin B12 and his vitamin D, and we arrange a bone density scan given the ileal involvement. And we address the smoking, not as generic advice, but ASA disease-modifying intervention specific to Crohn disease. Drug selection by severity is a topic of its own, and it is covered in the IBD management video. We also counsel him on thromboembolic risk during flares, and on the need for infection screening before biologics. Let us bring it together. Crohn disease is transmural, patchy, and it runs from mouth to anus. Pain and weight loss led the presentation, and the diarrhea is often non-bloody and mucus-containing. But half of patients have a positive fecal occult blood test, so test rather than ask. Diagnosis needs ileocolonoscopy plus small bowel imaging. Granulomas appear in under a quarter of biopsies, so their absence excludes nothing. Transmural inflammation explains perianal disease, stricture, fistula, and abscess. Endoleal disease costs bile acids, fatty acids, fat-soluble vitamins, and B12. And surgery is not curative. Disease recurs at the anastomosis. These are the sources behind today's material. The clinical picture, diagnosis, complications, and prognosis follow the current Lancet review of Crohn disease. The detail on clinical manifestations follows the Nature Review's Gastroenterology and Hepatology review. The definitions and overview of inflammatory bowel disease follow the New England Journal review, and the Epidemiology and Pathophysiology follow the Lancet reviews. Thanks for working through this one. Remember the single word, transmural. Almost every complication we covered falls out of it. See you on the next topic. Ulcerative colitis is the companion video to this one if you have not watched it yet.